when you look at replacing PACS, it can be a pretty daunting experience, and not only that, but costly. And to minimize the problems and minimize the expense, we wanted to utilize as much of what we had as possible.
Now we have access to the reports, to the prior studies, to the images, and we can quickly dictate that on a voice recognition system. It's radiology that is real time and on time, and that's the best kind of service for patient care.
We're glad we replaced our PACS. It's given us a lot of tools that we haven't touched on. Obviously, the increased productivity has been tremendous. We've got a better client for the referring physicians to use. Having the new client that will go on multiple platforms is certainly great. And then the other thing that's really helped us is we have auditing tools available in the new system that, just due to technology and HIPAA, has really come to the forefront. And now we can do a lot better as far as auditing who's touched an exam and everything that's happened to the exam for its whole lifetime.
Hello, I'm Mary Tierney, the Editorial Director of Health Imaging and IT Magazine, and I'd like to welcome you to today's webinar, A Smarter Approach to Replacement PACS, sponsored by CareStream. Replacing PACS is a big priority to a variety of facilities these days and to radiology departments. In fact, about 20% of departments and facilities will replace their PACS this year and next. Choosing the right next-generation PACS comes down to better, stronger, faster, more efficient, and less expensive. It needs to be better for radiologists, both user-friendly and fully integrated with voice, 3D, prior studies, and EMR data. Easier access on mobile devices for referring physicians also is becoming a priority. And to make the project affordable, replacement PACS must enable better workflow, decrease report turnaround time, and leverage most of the existing infrastructure. Today we'll hear from clinical and IT thought leaders at St. John Medical Center in Tulsa, Oklahoma, and Winthrop University Hospital in Mineola, New York. For St. John Medical Center, the tipping point for replacing PACS came with the installation of digital mammography, plus a desire to capitalize on 7 years' worth of data in their legacy PACS. The integration of their new CareStream PACS to the existing archive was completely seamless to clinical users, as well as saving significant dollars for the facility. What Winthrop needed was a new, better integrated RIS PACS, as well as an affordable pay-per-use model. And that's what they got, to eliminate the problems of their prior PACS, minimize expenses, and maximize clinical workflow for better patient care.
From a radiologist standpoint, helping the patient, the best way we help the patient is to get an accurate report out quickly. We need to make sure that all of the images or all of the reports that we generate are timely and they're accurate. My contribution to patient care is really getting an accurate report out quickly and letting that referring physician know as soon as humanly possible. I think what really makes a PACS system user-friendly is workflow. Being able to get the studies hung, read, and move on to the next case as quickly as possible. In the past 5 or 6 years, I've been exposed to 4 systems on a fairly regular basis. CareStream has been the primary that we've used for the past 5 or 6 years. And it's by far and away my favorite. I think it's the most user-friendly out of all of them that I've used. One of the really nice features of CareStream, something that I've appreciated since I've been using it, is the ability to do 3-dimensional reconstructions and also multiplanar MPRs, basically at the click of a button. It's as simple as pulling over, say, an axial set. You get an axial set of images on an abdomen and pelvis, and you want to reconstruct sagittal and coronal reconstructions. It's as simple as right-clicking. It's a drop-down menu, MPR, and basically within 6 seconds you have multiplanar capability. And when I say multiplanar, it basically gives you an axial, sagittal, and coronal with reference lines. If you're working with multiple institutions, which we are here, we have 5 different hospitals that we use, and we have images coming over. The important thing is that all of the studies are homogenized. At the end of the day, really what's important is saving time. And some of the other PACS systems that I've used really take a lot of time. They stop your reading. You have to really stop and think, okay, well, I have to push this button, then push this button, then push this button to get back to where I need to be, versus just knowing exactly where to go, hitting it, and going right back to what you're doing.
St. John Health System is a 5-hospital system that, with St. John Medical Center being the flagship. We are licensed for 750 beds. We run about 550 beds on a daily basis. The medical center's radiology department is pretty much a full-service department. We have 3 MRIs, 5 CTs, nuke med. We have 4 cameras in the nuke med department, 4 or 5 ultrasound units, array of diagnostic, radiology rooms and fluoro rooms. Purchased digital mammography about 4 years ago, and it became pretty apparent at that time that our current PACS was not going to handle the situation the way we wanted it and the way the radiologists wanted it. We wanted mammography hanging protocols, but we also wanted more than just a dedicated mammography read station that most digital mammo vendors have. We wanted something that would show MRIs or CTs or any array of imaging that the mammo radiologists wanted to review while they were looking at the mammograms. I think one of the biggest pieces was that we could capitalize on our current existing PACS, our long-term archive. We left that in place and actually still have it in place. So we put a front end with the CareStream side and migrated data over to that and still use our long-term archive, so it wasn't just a huge complete replacement, but it was a complete replaced front end. Radiologists are still on site. I mean, we have to have radiologists on site, but instead of having 20 radiologists sitting here in our hospital and have to make reading rooms for all of them, 6 of them or 7 of them can read remotely. So they're still involved. So our turnaround time for ER is virtually immediate. We're now a certified stroke center, so we have to run reports on CTs, and our average time, now this is average time from the time a CT is ordered till the final report, is 16 minutes. Well, if somebody wants to replace their PACS, the big thing to look for here, in my opinion, is your data migration. That can add a lot of costs, so you need to look at what that's going to cost you, or can you keep from migrating your data. Our EMR is integrated with the PACS system. When the referring physician clicks on the patient, clicks on the report, he can view the report, and there's a little tab there that they can click on to view images. And when they click on that, they get the full set of images. If it's MR, CT, our radiologists don't mark key images, so they just view the whole thing. If I was looking today, besides the standard next-gen PACS that everybody's going to be offering, you're going to have to make sure that they're going to connect to mobile devices. That is going to be the #1 thing over the next 2 years, I think, is every physician wants to look at images on their mobile devices. PET-CT is a problem, especially viewing the fused images especially the radiation oncologist and the medical oncologist. They want to see those PETs, and they want to see them fused with the CT, and we are able to give them that now. And if you have a big oncology business, you need to make sure you have that capability with your PACS system.
Well, our implementation was a little different than most sites because we had an existing system, so we were able to establish our new production box, test it, and do a complete cutover. And it's important, I think, when you're doing that, is to be able to have 2 separate systems so you don't have any downtime, and then you can pre-populate the data on your new system so you can actually make a clean cutover at any given point in time. I think you have to look at how it's going to operate with your existing modalities. Most systems now should do that with no problem. I think it's also important that if you have any legacy data, that it's all in a format that you can use in your new system. I think the critical piece being that data is stored in DICOM formats. The important part on the archive was we had 7 years of prior data, over 3 million exams that we needed to have access to immediately when we set up the new system. And the way the takeover works is it actually does a DICOM query to your existing archive, and it brings the metadata over, but it does not bring over the physical bit data of the images. So you can basically, they designed the takeover on our system that we could do a month's worth of our data in days. And so we were able to do 7 years worth of data inside of 2 weeks. The VR system, as it relates to PACS, is critical. The integration is important, and it has to be seamless. It's got to be easy for the physicians to use, because if it's not, you spend all of your time troubleshooting links between the 2 systems. And I think that's one of our advantages with the CareStream and the PowerScribe system. It all links together well, and it's a seamless process, and that is critical.
Winthrop University Hospital is a 590-bed multi-specialty hospital. We provide comprehensive care to our Long Island community. I am the Chief Medical Information Officer here for the last 5 years. I've actually seen Winthrop through a very big implementation for health information technology. We were one of the first on Long Island to have CPOE, as well as now preparing for meaningful use. like many organizations in the New York area and across the country, we're preparing for accountable care organizations and health reform, and we're expanding very, very rapidly, acquiring new practices at a very rapid rate, and also looking at our different strategies for our growth. And we felt that having a new PACS risk system that had the ability to flex with us as we grew and our volume expanded was going to be better for us strategically. You know, we wanted to move forward in regard to digital capability, having the ability to archive our images in a more reliable fashion, and also being able to reach out to our outpatient customers, our physicians that were in their private practices, and truly have accessibility to their images that were in these private practices that they weren't able to access easily. So having this opportunity to go with Carestreams and their financial model and the fee-for-service, it really provided us a nice safety net in regard to our operational costs, not having that much of an increase, but yet gaining such unbelievable technological advancement. When Carestreams offered us a disaster recovery solution as part of our plan, it was a no-brainer. We knew that this is the way we had to go, diversify our disaster recovery plan, not have it all in one place, because we know that building that redundant data center in a separate zip code definitely was the plan of yesterday. Now we know with cloud computing that we have many more options and a lot more cost-effective options, and that this plan actually offered us that. It really did offer us that opportunity to step back, look at the technology that was available, see that we could combine our risks and our PACS effectively and efficiently, and also moving towards a more of a managed situation as opposed to a nuts and bolts server-based configuration, also offered us the opportunity to, from a strategy perspective, be able to grow as we grew, as well as having that partnership with a very innovative company that wanted to really work with us to make it better. We're willing to work with the vendor because we believe the technology is so dynamic. We never should just settle for what it is, and really be partners in regard to making the product better as we go on.
When you do something like this, you have to get together and talk about it and discuss it. Well, should we switch? What's necessary to make that move? And then if we're going to make that move, what's the timeline going to be? What are the considerations and factors that are going to take place? How can we best do this without disrupting? Because we know when you switch a PACS vendor, it's a major decision. You have to be able to take information and change it from one platform to another, data migration, training, modality connections, etc. All of these factors have come into play, and if you're not careful, you can create a bigger problem than the current one that you have if you don't plan carefully. We'd rather just have one user login and access both the PACS, the risks, and the voice recognition technology in one shot, and that it's all integrated. The fewer interfaces you have means the fewer baton handoffs you have in a system, the less likelihood you'll have a dropped baton, and the more likely you'll be able to complete your race. I like the fact that you can do immediate 3D reformatting on the fly. I found that extremely valuable. I'm a neuroradiologist, so I look at a lot of cross-sectional studies, both MRIs and CTs of the head, neck, brain, and spine. And this sort of functionality is very crucial towards that. The teaching file capacity of the system was just phenomenal. It's done very simply and very elegantly on the Carestream system, and I think that's a major advantage that will appeal to many, many academic radiologists. I think that PACS will become integrated not just within radiology, but within the remainder of the clinical enterprise. I think that PACS will become a part of the health information record of that patient. All your images will be linked. The PACS images and your lab images, even your pathology report. Video clips of any operative procedures will be included in there. It'll all be together.
The original PACS system was designed to handle the needs of the department and some growth. One of the things that I think we've watched as technology has changed is the growth of 3D. 3D imaging, so now you not only did you have 3D imaging and ultrasound, but we had 3D and CT and angio. Then the growth and the change in our complexity where we started to go off towards breast MR, and then 3D reconstruction, functional brain imaging, the size of our studies actually grew. So, you know, if you look at a regular diagnostic x-ray of about 11 to 12 megabytes per study to going over a gig as we start to get into the CTAs and the MRAs, all of a sudden you started to realize that the system was not designed to handle this kind of volume and the size of our studies. It wasn't just upgrading PACS. That would have meant requiring upgrading the RIS, updating voice technology, updating PCs. So at that point, you might as well look at what else is involved to do this. Carestream was the one that had everything incorporated into it. Everything was built in. There was no add-ons. We didn't have to buy any other systems to make what we wanted done. The paper procedure is the technology enhancements down the road. It's not just that I'm going to buy this technology today and I'm going to handle all of the volume. This is a system that's going to continue to grow with us.
I still remember the first day. People were sitting around twiddling their thumbs, looking around, wondering, wow, what's going on? With the same amount of workload, I would say the time halved.
We'll do a better job. We'll be better diagnosticians. We'll be able to compare ourselves to our colleagues. We'll be able to generate graphs of how we perform with respect to diagnostic accuracy, with respect to turnaround, and we'll be able to gauge our performance along those lines within reason. And I think we'll be able to do a much better job.
Thanks for listening to today's webinar. To continue the discussion, just click on the link below.